Well, hello, everyone, and good afternoon. And I just want to welcome you to today's Congressional Neuroscience Caucus on post-traumatic stress disorder among COVID-19 healthcare workers. We're hoping to have a good exchange and that this is informative for all of you who are participating. I'm Dr. Steven Sterkowski. I'm the Vice Dean of Research and Associate Vice President of Regional Mental Health at Dell Medical School at the University of Texas at Austin. And today I'm actually serving in a couple other roles. I serve as on the American College of Neuropsychopharmacology Liaison Committee, where I'm the chair. And I'm a current board member of the American Brain Coalition. And so again, appreciate you joining us. The American College of Neuropsychopharmacology and the American Brain Coalition have partnered with the Congressional Neuroscience Caucus to host this briefing, to examine the critical need to address the psychological impact of COVID-19 on our essential healthcare workers. This partnership reflects the ongoing commitment of both organizations to improving mental health care in all Americans and worldwide. And so we feel this is an important topic to help continue to educate on and think about. The Congressional Neuroscience Caucus is co-chaired by Congressman Earl Blumenauer and Congresswoman Kathy McMorris Rodgers. And it was established in 2010 with the intent to build awareness of the intrinsic role that brain research plays in how we understand ourselves and our society. In order to help us communicate the progress and benefits of this research, we have these sessions, and to promote changes in federal policy that support neuroscience research so it can be applied to improve the lives of Americans. Before I introduce our first speaker, I'd like to remind folks we will hear from our three excellent speakers and hopefully allow for some time at the end for some questions and answers. Please feel free to include your questions in the Q&A box on the screen. I'm assuming many of you have, unfortunately, like me, gotten too accustomed to Zoom in the past year and so know how to do that. If you have any questions, though, just send something through the chat function. So good. So to start, we'll first hear from Dr. James Murrow. James is an associate professor of psychiatry and neuroscience and director of the Depression and Anxiety Center for Discovery and Treatment at the Icahn School of Medicine at Mount Sinai. Dr. Murrow, I will now turn it over to you.
Thank you, Stephen, and thank you for this wonderful opportunity, and to all the attendees. I will, let's see. For me to share, someone has to stop sharing. Let's see here. Testing my Zoom knowledge here. Okay. Is that looking okay to people? All right, wonderful. Well, thank you again for this opportunity. Really exciting. Wanted to share with you some of what has been going on with our research and what we've experienced in New York City regarding COVID-19 stress and mental health. Just a quick slide on my disclosures. I've had some consulting with companies and a few patents filed, and none of this is related to what I'll be talking about today. So I put this together as I was sort of trying to go back and frame and think about what was happening in New York City in March, April, May of 2019. I got a few snapshots going back to the New York Times. It's hard to emphasize the fear, the intense uncertainty that was going on, of course, across the city, across the nation. I think New York City was among the earlier waves of this pandemic. And then in terms of what was happening in the hospitals in the city, it was a very scary time, a very intense time. You can see here round about early March, April, the new cases were peaking at 10,000 new cases a day, peaked on April 10. This was a disaster unfolding in front of us. For those of us that were around when the World Trade Centers were hit in New York City, there was a lot of feelings and remembering of that. You see this spike in hospitalization and death. Again, this is just New York City. Different parts of the country experienced these in different ways. Our dean, Dennis Charney, put a quote from him saying, "We were the epicenter of the epicenter," and at that time, the feeling of really a tsunami that we were in the middle of, and we weren't sure exactly how long it was going to last, what was going to happen, and how we were going to get out of it. Just very briefly, of course, we're talking about what we might call the psychological trauma of COVID-19. So just very briefly, kind of to orient, how do we think about this stuff? I mean, we know that stress is not a bad thing in and of itself, but if it's too intense or too long, has certain characteristics, it can lead to negative mental health outcomes. Most commonly, we're talking about, of course, what we describe as PTSD proper, and I've sort of listed some of the symptoms down here, but also even more commonly, depression, anxiety, chronic worry, and this will be reviewed for most of you, but as stress increases, this is a classic curve. Actually, performance goes up in general, and then we hit some point, and then bad things start to happen. And this is data that I just grabbed from the CDC website, survey they conducted, and you just see the numbers here. There's lots of different forms of this data, and we can get into this, but we see very high rates that are concerning among, this is the general population in the middle of the pandemic, looking at 30% responding to having depression or anxiety, 26% that might be considered more of sort of post-traumatic stress, and you see some of the symptoms there. This is recurrent intrusive nightmares. Just a minute on depression, because I think just to take a step back, and this is one of our areas of interest, is depression. How do we understand it? How do we find out how to prevent it and treat it? Depression is among the most common, if not the most common, of all medical disorders, and by some measures accounts for the largest disability worldwide of any medical condition. And so just to put that in perspective, this is before the pandemic, before COVID. Depression is a huge public health burden. And I just thought I would put this in. I pulled this from a Nature article way back in 2014. But if you look at other major drivers of disability, in terms of the funding, it's relatively low. The funding through the NIH that, of course, supports the lion's share of research in the United States on all things health as well as mental health, about a tenth is spent on depression versus other major drivers such as cancer. So I just thought I would point that out. And again, just showing on the right here, from February 2021 in Nature, another estimate of proportion of US adults reporting at least symptoms of anxiety and depression. This is in December 2020 compared to previously, and you see some really alarming rates, 42% there. But the focus, I think, for today is how do we understand and prevent or treat the psychological effects among specifically frontline healthcare workers. So that's what I'll spend the rest of my few minutes talking about. I mentioned 9/11, so I went back, again, particularly from the New York City perspective, thinking about, I found this article written and published back in June of 2020 by some of my colleagues, sort of lesson learned from 9/11. How do we think about measuring, preventing among our frontline, our first responders, right? And a few points here, and I'll just direct you if you would like more information to the citation, but sort of can break this down in terms of how do we prevent. You have to measure it before you prevent it. Basic things that are sort of common sense about, but operationally, how do we provide social support, build communities, concept of a trauma tent. We have to create actually physically safe space for individuals, frontline folks that are suffering from exhaustion, and then gathering city, state, sort of volunteer mental health support services. And also early on, it was noted, again, going back to 9/11, the World Trade Center a monitoring system that was established by Congress that's still going on has been unbelievably helpful in terms of monitoring, tracking, and treating people that were exposed and suffering either psychological or medical health problems based on the World Trade Center disaster. We think something like that for the COVID-19 disaster is going to be hugely important. So I just want to share with you a little bit what was happening. So this is something I grabbed. Sabina Lim at our medical center was really heading this up, sort of putting together a multi-level, in the Department of Psychiatry, we were aware that our colleagues on the front lines, most of us in psychiatry, we were not on the COVID units, we're not on the front lines, but how do we treat and prevent and provide support for the mental health problems that unfortunately we know are coming. And you can just see this kind of how we think about it. But I kind of want to zoom in for a minute because this is kind of where I was able to get involved a little bit. This level 2, we call this mental health PPE, and I'll share with you a little bit about how this worked. So basically, again, this goes back to, this was in March, April, May. Teams were organized from the department, 2 to 3 per team. We underwent basic training in what was called psychological first aid for first responders based on guidance from SAMHSA that was extremely important. This was largely led by Craig Katz. And then we were assigned to COVID units all over the city at the different hospitals that are part of the health system. So for example, I was assigned to a COVID unit. It was a surgical unit that was converted to a COVID unit at a hospital in Queens. And we would reach out, try to let the nursing managers know, let the staff know. We would put up flyers. This is our cell phones. When do you want us to come by? And it was a process. But we would try to make ourselves available, set up impromptu support group sessions in the nursing lounge. And this was sort of one glimpse at what did we do to try to sort of get in there and sort of mitigate and provide support to our frontline healthcare workers. And like I say, the basic orientation and training actually we gave the members of these mental health teams largely followed this tried and field tested guidance by SAMHSA that was very helpful. This is just an example of the flyers we would put up or circulate. We found that one of the challenges was just to get the word out. You know, a lot of these units, I mean, they were so buried in their work, in cases, the stress, the exhaustion levels, and we would be sitting around sort of prepared to act and not hear anything. And so we went through iterative process. How do we reach out to these folks? And it turned out that every unit was different. So we had to learn to be flexible. Here, this is an actual picture of what we put up in the nursing lounge. I blocked out our cell phones, but so let me just in the last few minutes just share with you a little bit of data. I mentioned that, well, we have to know what is happening in terms of mental health to our frontline healthcare workers. So I'll just share with you a little bit of data from a survey that was conducted at the Mount Sinai Hospital. In terms of the hospital census, the peak cases were April 9, 2020, and the survey was administered April 14. And just very briefly to show you some of the data, basically we blasted out to everyone we could figure out that might meet this criteria of a frontline healthcare worker. We ended up with about 3,000 responses that had adequate data, and we were asking a couple of very basic things. One is we were using validated measures of symptoms of 3 main negative effects of severe stress that I've already mentioned: PTSD, depression, or more formally, major depressive disorder, MDD. And then among the most common form of an anxiety disorder, which is generalized anxiety disorder, or GAD. And again, we had scores that sort of on validated measures that individuals would complete. And then we asked a bunch of things that we thought might be risk or protective factors, all kinds of information about their personal demographic factors, coping strategies, how much exercise did they get, that type of thing. And then we asked some basic questions. There's a lot of data, and actually it's a multi-wave survey. So this is just a snapshot of that very first wave. Okay, you see on the left, simply, okay, what proportion of the respondents reported a threshold level that would be considered like a screen positive, but not a confirmed diagnosis, but at risk, substantial risk for one of these 3 main disorders. They're ranked by, so you can see, kind of in line with the theme I've been mentioning, we're really worried about depression. This in this survey was among the highest at 26.6 of respondents indicating or perhaps meeting threshold for major depressive disorder. Overall, almost 40% reported indicated risk for at least one of these. And then very briefly, just a few things, because I know we're short on time. What were some of the factors when we looked at risk for having one of these negative outcomes, such as depression or stress or PTSD? So you see here with just a few of them that kind of came to the surface. If you have these factors, you were actually at higher risk than your peers. If you indicated high levels of burnout at work, before the pandemic started, unfortunately, you were at a greater risk than your peers of actually suffering one of these outcomes in the context of the pandemic. If you reported challenges in terms of establishing a balance between work and life, work-life balance, you were at risk. And if you indicated having a greater medical risk based on the individual's own medical history, you were at risk of having one of these stress outcomes. On the flip side, factors associated with lower risk were feeling, the two top ones were feeling valued and supported at work, and also being married or partnered. Just very briefly, this is my last two slides. Just want to briefly touch on the concept of resilience. So at the same time, separate groups were working on basically taking what we knew about how to bolster resilience and putting together essentially workshops and inviting employees to take place in these workshops that were sort of developed and are still being refined. And they're built around some of the basic, the work of Steve Southwick and Dennis Charney and others. And you can see sort of each workshop is focused on a core component of what we think is important to build resilience. And we're working on getting this in a digital app format. Very last thing in terms of the need for research and care, I haven't really mentioned, but the post-COVID, what about people that actually get sick with COVID? We know very little, but we have reason to be concerned that these folks in the general population are going to be at risk of suffering one or more negative mental health or brain-based problems. This is a little bit of data for a prospective registry that we've established, and already at enrollment of the registry. So you could get in if you were a patient that ever had COVID, were treated anywhere in the city, at home, hospital, ER. About 700 patients have volunteered to be in the registry as of a few months ago, and 30% are endorsing moderate or severe depression, so not even mild. And if you were hospitalized or in the ER, we're seeing a rate of risk for PTSD of 25%, which is alarming. Again, this is just knowledge. We have to know what the problem is, and a lot of research is going to be needed to understand what this is and how do we treat it. So with that, let me just conclude for you. So I've talked a little bit about and hopefully conveyed the concern in the field about COVID-related stress and trauma in terms of risk for depression and other things in frontline workers, but also general public. We think it's very important to have proactive measures to monitor and treat mental health problems. And I mentioned these numbers. We're looking at, unfortunately, nearly 40% may have significant problems. I think with that, and as I mentioned, much more research is needed to understand these and prevent them. So with that, let me conclude. This was a big team. Some of our depression center has been involved in this at the medical school, as well as a new center for stress and resilience. And some of the folks listed here are authors on some of the research that I presented. So I'll stop there and thank you so much for your attention. And I will, shall I stop sharing?
Great. Okay. Thank you, Dr. Moreau. That was very, very helpful. And as a reminder to all of you who are watching out there in the audience, please feel free to put questions in at any time, and we'll get to all of those at the end through either the Q&A function or the chat function. So it's my pleasure then to introduce our next speaker, Dr. Kathleen Reesmeyer-Kangas. She is a senior investigator and chief of the Genetic Epidemiology Research Branch in the Intramural Research Program at the National Institute of Mental Health. Kathleen, I'll now turn it over to you.
Thanks very much. Thank you for inviting me to take part in this panel today, where we're discussing a very important public health topic. As an epidemiologist, one of the positive effects of COVID-19 is that the term epidemiology is now a household word. When my children were growing up, they always struggled to explain to people what I did. So today I'm going to be talking about the use of the tools of epidemiology to characterize mental health, and particularly stress syndromes and PTSD in the general population of the US, and how that's been related to societal changes associated with COVID-19. So I'm moving us from the clinic to the general population, which are both very important sources of information in our understanding the implications of PTSD for treatment and prevention. So here's my disclosure. I'm at the National Institute of Mental Health Intramural Research Program. So I'm going to present with an overview of the impact of COVID-19 research in the general population. Dr. Moreau just introduced us to the increase in symptoms in the population. I did want to comment that we really don't have a national database, so it's very hard for us to estimate the rates of PTSD, post-traumatic stress syndromes, anxiety, depression, because the information comes from multiple sources. It can come from electronic health records, insurance claims, and also surveys. So each of these sources has limitations in terms of the extent to which they represent the subgroups of the population and the quality of information on mental health symptoms and disorders. Then I'll describe some of the factors related to differential risk in the population. And finally, I'm going to present a brief summary of some of the work we've been doing, both in the US and other parts of the world. So what have we learned about mental health and COVID-19? So there have been widespread reports, as we heard in the last talk, of a rampant epidemic of anxiety and depression. They've saturated the media across the last year. This survey by the CDC, and this was in June 2020, just at the beginning of the pandemic, found that about 40% of Americans reported at least one mental health condition. Ironically, even though the risk of COVID-19 increases with age, increased stress and anxiety are most elevated in young adults, shown here, where as many as 70% of people ages 18 to 24 reported mental health symptoms in June of 2020. Dr. Moreau just showed this slide, and here I wanted to make the point that there has been an increase both in the UK and the US. So we've had parallel increases in other countries across the world, but the bottom shows the fourfold increase of symptoms of anxiety or depression. So it seems that anxiety and stress are much more prevalent than depression in the population, and generally these combine to lead to mental disorders. So it's very important for us to look at the full spectrum of symptoms of stress, anxiety, and depression. So recent data from the CDC, which follow these data up till February of 2021, this past year, shows that these trends are slightly increasing with time. We might have expected a decline with the use and widespread use of the vaccine, but we haven't seen that yet. That has not been reflected in our records of general stress indicators in the United States population. Now, does this really mean that we have an epidemic of mental disorders in the country? Of course, as shown here, there's a continuum similar to blood pressure, where we can have people with no symptoms, moderate symptoms, and severe symptoms. So at the right side, these are the people shown in red who have prolonged, recurrent, severe distress and impairment. So apropos our meeting today, we have people at this end with post-traumatic stress disorder, and over here in the black, in the middle, people with post-traumatic symptoms. And if we look at the general population of the United States, the rates of PTSD are actually as high as 10%, but among healthcare workers, who we're going to hear about today, the rates are 20 to 30%, depending on the location and the distress associated with treatment of COVID in their hospitals and clinics. So turning to disorders, there have been several studies of the associations between COVID-19 infection and mental disorders across the world. And this is what our healthcare workers have been crying about in the country. This slide shows the results of analyses of associations between COVID-19 infection and psychiatric disorders from a large database of electronic medical records. And here we see these graphs where we have incidence rates or new cases of psychiatric disorders that are increased in people after they've been infected with COVID up to 3 months after the onset of infection. So on the left, we show psychiatric disorders, the middle is mood disorders, and on the right has been this increase in anxiety disorders, which has been quite evident in the United States in population and clinical samples. Now, these are compared to people who were treated for influenza. So it does suggest that there's some unique effects of the incidence of psychiatric disorders on people who suffer from COVID-19 as opposed to other flu viruses. Now, at the bottom of this slide, I wanted to call your attention to the fact that people with psychiatric disorders pre-existing prior to the pandemic also have an increase of contracting COVID-19. They have about a 1.5-fold increase, and we're not sure what this is attributable to, but possibly to increased exposure or their ability to employ preventive measures. So next, a pertinence to the group here today, these organizations involved in this briefing, we've learned substantial amounts of information about COVID influence on the brain. We know a lot about other viruses in the brain, but the COVID-19 may have some unique direct or indirect influences, such as prolonged sensory impairment and anxiety symptoms that should be documented and followed to gain insight into their longer-term influences on both physical and mental health. So this figure is a recent summary from JAMA Psychiatry that shows the ports through which the virus may pass the blood-brain barrier through the vascular system, and as it travels through the brain, it leads to disruption in several cell types, several regions, and chemicals that could be associated with psychiatric symptoms and disorders. In the next few slides, I'll describe the highly variable manifestations and impact of COVID-19 virus and their societal changes. So first, we know that there's abundant evidence that the burden of both COVID-19 infection and societal preventive measures has been highly unevenly distributed in the population. People with prior mental disorders, financial or food insecurity, people who live alone, and as we hear today, healthcare workers have been disproportionately affected by the pandemic. Pandemic has also been unevenly distributed at the level of communities across the United States. These 7 characteristics have been combined to derive a community vulnerability index that's shown in this map. So the orange shows high vulnerability, the turquoise shows low vulnerability, and the intermediate, the green, shows moderate vulnerability. Identification of those at highest risk of the consequences of COVID-19 should combine the community level as well as the individual level characteristics that I've just described. So most of our understanding of the mental health impact of the COVID-19 pandemic has come from traditional clinical measures that may not capture the unprecedented nature of the impact of COVID-19. So here I show 2 examples of the use of qualitative measures that allow people to tell their stories in their own words. They use machine learning tools to extract prominent themes to characterize the impact of the pandemic on people and their lives. So at the top, I've summarized the results of a Pew Foundation study of adults in the US, and they looked at open-ended questions to look at the positive versus negative impact of COVID-19. And here you'll see majority of people have both positive and negative influence. But the negative to positive balance is a little bit in favor of negative influence. Now, this negative to positive ratio increases dramatically at people at the lower levels of the socioeconomic ladder. At the bottom, These methods were used in a study conducted at the Child Mind Institute in New York in the laboratory of Dr. Arnold Klein and his team at the Matter Lab. And they used an online version of something called the crisis logger that encourages people to record their impressions of how participants have experienced the pandemic and how it's influenced their lives. So looking at the right here, one of the major themes that has emerged is the impact of families, particularly those with children with developmental disabilities who suffered disproportionately from the pandemic with loss of resources in their daily lives. So in the last few slides, I'd like to present some findings from our own work. We track the mental health influences of COVID-19 on adults and children through a collaborative effort between the NIMH and the Child Mind Institute, where we've studied people both in New York and across the world. So at the start of the pandemic, we assembled a multidisciplinary team of experts to create a tool called the Coronavirus Health Impact Survey, or CRISIS, that has now been used in diverse clinical and community samples in the US and other countries. Here we show how we've administered it both in the US and UK, and in our ongoing study of children in New York, the Healthy Brain Network, directed by Dr. Michael Millam at the Child Mind Institute. And I'll talk a little bit about what this tool detects and finally what we've learned from the application of this tool in the population. So rather than focusing just the symptoms of anxiety and stress alone, the crisis assesses the multiple domains of health behavior that have been influenced by the pandemic. These include substance use, health and other behaviors, such as media use and life changes associated with COVID-19. And these turn out to be very important in our predicting who is going to suffer from enduring impact of the pandemic. So we administered the crisis in several times to adults in both the US and UK. And I won't describe the details of this slide here, but this graph shows profiles of lifestyle changes associated with the pandemic. The main finding is that we identified a high stress group, shown in blue, that involves family problems, shown over on the right, few positive life changes, more stress from containment and financial problems. And this is the subgroup that seems to have the most risk of developing the mental health consequences of COVID-19. And finally, for the purpose of today's briefing, we examined some health and mental health indicators in children of families of healthcare workers in the Healthy Brain Network study. We surveyed them in June of 2020, where we just heard where the pandemic was really very affecting much of the New York region. And then we looked again in November of 2020 in this same sample. So here we compared the children of healthcare workers, shown in green, essential workers, shown in blue, and non-essential workers, shown in purple. And what we found was that children and families of healthcare workers had more COVID worries, lower sleep duration, more sleep problems, and both family and child health impact. This highlights the importance of consideration of the pandemic on families rather than on individuals that has been the primary target of public health testing, vaccines, and COVID-19 containment. So in summary, we don't find evidence for an epidemic of mental health disorders, but rather high levels of worry, stress, and anxiety that have somewhat increased in society across progression of the pandemic. But we do find that there's some increase in new cases of mental disorders directly associated with COVID-19 infection and worsening in those who had mental disorders prior to COVID-19 infection. And in assessing the impact and identifying those in need of treatment, we have to consider both physical and mental health, positive, negative balance of the impact, and clustering of risk in particular individuals and communities. Finally, the impact on families should be a major priority for public health policy. So I'd like to thank my collaborators on this work at the NIMH, Outside, and the Child Mind Institute. And in the last slide, I'm showing some links to resources for mental health for individuals, children, and families. Thank you.
Thank you, Dr. Merrick. I guess that was very, very ominous, but and interesting. And so our final speaker is Dr. Michael Broad. Michael's a practicing internal medicine doc at the Del Seton Medical Center in Austin and an assistant professor in the Department of Internal Medicine at Dell Medical School at UT in Austin. So Dr. Broad, I'll turn it over to you.
Yeah, thank you so much for the opportunity to speak today. And, I have the pleasure of being able to speak less from the epidemiologic and scientific aspect of it, but a little bit more of the frontline experience from providers. So I am a general internist and hospitalist. So over the last year, almost all my practicing as a clinician has been for patients hospitalized with COVID-19 in the ICU or in the hospital. And so I have no financial disclosures and want to talk a little bit about, just the experience from the provider perspective, the patient perspective, and then, of course, the future directions as we think long COVID or the post-acute sequelae of COVID-19 is going to be with us for a long time. And so, at least here in Texas, unlike New York City, we didn't initially see the tsunami that we were expecting and the Europe and the East Coast really experienced. But by March, we were really preparing for the tsunami. But instead of what we said of compared to Dr. Murrow's slides, at least in Texas and a lot of other areas around the country, instead of just hitting us hard and overwhelming us, what we experienced was almost a flood, and that cases rose and rose and rose until we were over our heads and overburdened as a healthcare system. I think with that, we were just asked to do more and more, and around the same time in the country that after 3 months in quarantine and people were tired and kind of giving up and we were no longer being delivered food every day as healthcare heroes, is the same time that in July and August that we really started to see our high numbers. At one point, almost half the hospital beds were just COVID patients and our ICUs were consistently full. And that almost maintained steady throughout the fall until we had our, I guess, second or third, depending on how you consider it, surge over the winter. And what did that mean just as a healthcare worker? I think early on, we all faced the uncertainty of, had we been exposed? We weren't testing every patient. So kind of looking cautiously and wondering, could I be sick? Could I be asymptomatic? Am I bringing this home to my family? All of us had a safety plan about, what would happen if we got sick. A lot of providers had arrangements where they were staying at hotels or, staying completely isolated from their family as they went into work. This was the same time, we weren't testing people and we also had low PPE. And so, on the pictures on the left and right were the good days, but we learned to ration our PPE. It was our prized possessions, and really trying to go into rooms and not wasting a single resource as we were struggling to keep up until our supply, really up until the summer, didn't match the demand. Similarly, I think from the provider perspective, nurses were asked to just do more and more. They were really the most heavily burdened group. A lot of nurses were not paid hazard time or hazard pay throughout the country, and just kind of told, as cases went up, they were just expected to work extra shifts. And they're the ones in the rooms for hours at a time, as these patients can have high needs on oxygen, can be confused, can have all the myriad of health effects because COVID-19 is a fully systemic illness affecting all parts of the body. And they were just asked to continue doing more and more, and they did it. It was truly inspiring, but that didn't come with a cost, to the families and to their mental health. And we experienced in our ICU about half of our staff is turned over the course of the year, leaving to other positions, trying to be travel nurses for higher pay. And, you know, compared to a year ago, I walk around our ICU and it's about 50% new faces for, you know, a lot of good, excellent nurses who just couldn't, just needed something different from the stress of the year. And similarly, you know, the other group that really affected two other groups, one of them being medical trainees and residents. And so these are doctors who have graduated medical school but are still in training. And they're some of the lowest paid, even from the custodial staff and other staff in the hospital. And, you know, they were just asked to work extra shifts to continue seeing these patients, seeing their education interrupted. And they weren't paid extra for that. They were just told this is part of your training. And in a lot of ways, they learned a lot. But in the highest group, about 30% of residents at any time are experiencing clinical major depressive disorder. And we don't have good evidence of what that rate is now, but I suspect it's extremely high of going through some of the most stressful years of medical training in quarantine and isolation and with a high burden of patients. So I think, you know, for the provider perspective, what's going to be really important is that it's interesting, you know, in some ways, this pandemic has inspired a new generation of clinicians and students to join the healthcare workforce. And it's going to be so important to not only understand what the burden of mental health illness among healthcare providers is, including burnout, PTSD, but to provide resources for them. As this new generation of students and young people join the workforce, we want to have a workforce that is there for them, that isn't burnt out, that isn't completely tired and moving on to the next thing, that we want to be able to continue to inspire the future generation. And that means our mental health is going to be at the forefront of that too. And I think, you know, this is our faces in medicine, the mortals in medicine. It's just going to be extremely important, you know, dealing with the loss and the grief of this year. You know, my colleagues being doctors and head of departments, but also homeschooling teenagers, you know, dealing with death of family members for COVID and non-COVID, and having Zoom funerals and then going to their next shift, and just all the things that, you know, my colleagues have seen. It's going to be a process to deal with. But at the end of the day, you know, I think I write our guidelines for COVID-19 treatment, and we're getting much better at this. And I think we have a model of what is effective. And what it is, it's not a single treatment. It's not a single pill that we can give. It's really our workforce. It's been shown over and over in studies that high burdened areas of COVID-19 have worse outcomes, and that as the health system is stressed, that there are more deaths. And so our ability to maintain a workforce to meet the next pandemic and even get us through this current pandemic is going to be important, because, you know, unlike the beginning when we were just overwhelmed and overburdened, the mortality rate was 20%. And in places where we're able to maintain staffing ratios that are low and appropriate, it's down below 7%. I'll just finish, you know, with the last 2 minutes of really saying you know, being a patient in the pandemic is also a huge burden. I had one family in the ICU just camp outside the hospital across the street because they wanted to be close to their loved ones when we weren't allowing any visitors. And you can just imagine what it's like having a life-threatening illness for many people who had never been sick or hospitalized before and on the verge of dying in the ICU, surrounded by people in masks, kind of being fully in isolation, treated as a threat to other health, to the people trying to take care of you. And what that does to the patient for PTSD, what that does to the family members who, how do we even describe what it's like to be on a ventilator and prone? For all our staff trying to describe that on the phone, and a lot of this care happened out of sight. And as a patient, to try to explain that to your family or your boss when you're trying to return to work, I can't even imagine what that's like. And so, you know, this is The last thing I'm going to talk about is a little bit of, we have a pretty good understanding of how to treat acute COVID in the hospitalized setting. And we've all been watching this over the last year, but as our other panelists really mentioned, how interesting this is, what it's going to take for the long haulers or post-COVID, long COVID, and just all the myriad of health problems for those who were severely ill and have problems with their health for the rest of their life, for those who just had mild illness and never fully recovered. We're seeing very high rates of PTSD, anxiety, depression. You can see that almost 40% of patients in the study out of Michigan have been unable to return to work. So this is a life-altering disease, even if you just got pretty minor symptoms. And I think it's just the beginning. In some ways, like I showed on that mortality slide, we've come so far on how we've been able to manage and understand this disease with funding, focus, and all scientists and clinicians collaborating. And this should really be the model of the future of medicine, of this collaboration and kind of the moonshot, with all of us focusing on the same disease to really unlock, what are the immunology, the mental health effects. And this is a real opportunity for a discrete disease to keep on learning. So thank you so much for the opportunity to speak.
Great, thank you, Dr. Broad, and all the speakers. So at this point, for the last 10 minutes or so, we have time for some Q&A. And so if you have questions, please send them to us in the Q&A box or the chat box on Zoom. Our first question, I think you all have kind of implied the answer to this, but I'd like to have a more explicit conversation. So, and I'll frame it a little bit. With vaccines rolling out and everybody really struggling to get back to life, are these problems going to correct themselves as we normalize? Or do we need to think about managing them over a longer period of time? And if y'all could guess how long do we think that is? And then related on that question was, and if it's the latter, what do we need to do that we haven't done already or not doing enough of? So any of you who want to talk open on that, that would be great.
Steve, I could make it, James here, I could make a comment about that. I think, and I hope it's sort of come through in the presentations. This is going to be a long-term project. I hope no one underestimates what we're dealing with here. People, we use the term pandemic, and I know Kathleen did, but at least simply the way I think of it is there is a mental health pandemic unfolding basically in front of our eyes that we don't fully understand the scope of. So I think that we need organized, proactive response. And the first thing that comes to mind is just harking back to, again, the discussions in New York City about the establishment at the federal level of the World Trade Center health monitoring system, creating a set of for funding over the long term sets of clinics and research systems to address, track, treat, and conduct research. And it's going on today, well over 10 years later. And very early on, when we were seeing this happen in March, April, May of 2019, essentially, even at that time, we were sort of waiting for the word from on high, aggressive federal support to establish something that looks like what happened after 9/11. Of course, 9/11 was just one city, and this is across the whole country and, of course, the world. So unfortunately, this is not going away, and this will have to be addressed with proactive, I think, funding to set up networks of clinic and research centers to address this.
Any of the other panelists want to add to that? Okay, good. Yeah, go ahead. Go ahead, Michael. Sorry.
I was just going to briefly say, I think going forward, two things that we've really seen of, in some ways, our healthcare system has split both physical and mental health. And as we're seeing, especially for post-COVID, that they really should be viewed as one of the same, and having a full capacity to care for these, the large amount of patients that need help will be extremely important, supporting psychiatry, social work, therapy, all those things. And I think the other thing that we didn't talk about is, how it has disproportionately affected vulnerable patients, Black, Latino, Indigenous. And so not only having a workforce that can meet that demand, but also meet it in a culturally appropriate way with good representation and speaking the primary language of those patients is going to be extremely important.
Great. And relate that, we just got another comment. I mean, we know historically that mental health access has been a challenge. So what will we need to do differently or more of, do you all think, to meet this upcoming mental health wave, as one of our attendees is calling?
I mean, Steve, I can tell you that, yeah, we knew even just from our local health system perspective that this wave was coming, and it came. And, whether it's anecdotal, whether it's calls that we're fielding or are going to the main clinics that support mental health, it's real hard to get an appointment. There's a very long backlog. We are short of being able to meet the demand of mental health services in the wake of COVID, clearly. And unfortunately, it exacerbates a problem that's been going on for a long time. It's something about the structural aspects, whether it's about reimbursement, figuring out how to get enough doctors, social workers, psychologists trained, accepting enough patients of all different levels of insurance status. That's been a systemic problem that when I was first graduated from medical school, that I guess I was probably naive. I saw that up close in New York City, and it's a little bit alarming. It's hard to get an appointment for most people with a mental health provider, and that was way before COVID.
And I can comment on that as well. I think what the COVID-19 has done at the level of the population is exposed a lot of the inadequacies in our healthcare system and access to care. I think one of the positive developments has been our increased ability to do online treatments and to begin to learn how to get reimbursed for those, as you said, because that's one of the challenges, but also to build an evidence base of the use of different levels of stepped care. And sometimes 1 or 2 sessions has been found in other countries to have dramatic impact on the high stress level of people, with others then funneling them through stepped care to actual more intensive treatments. So I think if we come together at a national level and think of how we can provide care across the population by engaging primary care practitioners, as well as developing online treatments that don't require you to come in locally where we have a lack of mental health clinicians, I think that's going to be something that got started by the pandemic. And I think it's something we need to put a lot of effort to in the future.
That's a great comment. I was just thinking in Austin, we went from essentially no virtual care to 100% virtual care in less than 2 weeks, simply by removing what were truly artificial barriers that have been set up to mobilizing. And so I hope we keep that intact, removing those. So there's a bunch of questions coming in. So I'm going to try to combine them around post-traumatic stress disorder. A number of people ask questions of, do we need to worry about the rates going up? Do we have treatments available that can really help manage this? And how will we take care of the PTSD that comes from both being ill and from having to take care of people from being ill?
I mean, Steve, I could just take that. I mean, should we be worried? Again, I hope it was clear, the presentation. I mean, I'm worried. I think there's a good reason to be worried, and that's, I think, why we're talking about this today. What do we do to try to get in front of this? And it a little bit dovetails with what we were just talking about. I mean, we know how to treat PTSD. There are good evidence-based primarily psychotherapies, but they're expensive to deliver because psychotherapy is relatively expensive to deliver. And again, there were access to care issues, not enough psychologists that are well trained in evidence-based therapies for PTSD. And I think that is exacerbated. I don't have the answer about what we can do about it, but if the question is, should we be concerned about it and try to think about what we can do, the answer is yes.
Great. Any other comments on that? All right, good. Well, we're closing in on our time, so unfortunately, we're going to have to wind up. There are a number of other questions that we just couldn't get to, but we will try to follow up with you directly as much as we can. And we're also going to include some resources for you as well. We didn't talk about this much, but I want to say we're very grateful to have members of Congress and their staffers attending today, in addition to ABC and ACNP members and other supporters of neuroscience research. Thank you for coming. For those of you who are representing Congress, either by staffing or directly, you've heard the concerns that this is not going away and it's going to require some type of national response to help a mental health system that's struggling before the pandemic, particularly in underserved neighborhoods and populations. So we'll hope that first you'll go back and think about this and try to continue to assure robust and sustainable funding increases for biomedical research that includes mental health research everywhere that it occurs, NIH, CDC, SAMHSA, Defense, Veterans Affairs, because we not only need more neuroscience advances, but we need more access advances. How do we find new models of care that allow us to treat this second wave of the pandemic, the mental health wave? Second, for those of you who are House staff, if your boss is not a member of this caucus, we would really hope that you'll encourage them to join. We as a country are going to have to come together to manage the ongoing impact of this pandemic for some time to come. And so we're all going to have to jump in. I really want to thank Drs. Murrow, Marikangas, and Broad for their thoughtful insights, wonderful conversations, and we appreciate you taking the time to do this today. I want to thank the Congressional Neuroscience Caucus for partnering with the American College of Neuropsychopharmacology, ACNP, and the American Brain Coalition in hosting this briefing today. I hope those of you who attended found this useful, and I want to thank you for joining us and have a great day.